Welcome to this class on the fundamental principles of first aid. We are going to provide you with essential theoretical tools to help guide you in applying life-saving techniques. The first thing we need to define is what first aid means. First aid refers to the techniques or procedures you will carry out when assisting a person who is experiencing a medical emergency or urgent situation. Let's think of some examples of medical emergencies or urgent situations. A fracture, a burn, a wound with bleeding, a stroke, a cardiorespiratory arrest. In other words, there are so many possible medical emergencies and urgent situations we might encounter, and we need to know what to do in each case. Now, the question is, what is the difference between an urgent situation and a medical emergency? And the essential difference between the two, is the risk to life. That is, in a medical urgency, there is no risk to life, while in a medical emergency, there is a risk to life. This doesn't mean that an urgent situation isn't important. An urgency is urgent, as the word implies. And let's not forget that a medical urgency, where there is no risk to life, can turn into an emergency within minutes. So in both cases, whether it's an urgency or an emergency, it's important to know what to do, how to act, and which technique to apply to assist that person and safeguard their life. Let's think for a moment about the worst possible medical emergency. What could it be? Let's think. Excellent. The worst possible situation is death. There are two types of death. Clinical death occurs as soon as a person loses their vital signs, as soon as their heart stops. And biological death happens 10 minutes after clinical death. From the moment a person enters clinical death, we have 10 minutes to do something for them. And with every passing minute, there is a 10% lower chance that this person can be revived. That's why it's so important in this case to start the CPR technique, cardiopulmonary resuscitation. It is one of the most well-known and widely practiced first aid techniques in the world. This technique allows us to reverse clinical death so that the person can be revived and of course regain their vital signs. So, everyone, with every passing minute, there is a 10% lower chance of survival. Therefore, when we say 10 minutes, it doesn't mean we can relax. It's not like we have a total of 10 minutes and at minute 9 I start doing something for that person. No, if I start at minute 9, by that point I've already lost 90% of the chances for that person to be revived and come back to life. So it is essential to begin CPR maneuvers as soon as possible. The sooner we start performing CPR, the greater the chance that this person will be able to tell the story. Next, we're going to understand a bit more about what CPR means. I'm going to share a three-dimensional simulator of the human body on the screen so we can see the cardiovascular system. We can see here in the chest of this simulator, behind this bone called the sternum, is the heart, which is the pump that makes blood circulate throughout the body. The heart is located between the sternum in front and the thoracic spine in back. It's the thoracic spine in the back. This pump, as we just mentioned, keeps blood constantly circulating in your body through the arteries and veins. And one of the most important functions of blood is logistics and distribution. What does blood distribute? Many things, but among the most important are the essential nutrients for life. And among the nutrients, the most important for this class is glucose. And besides nutrients, blood also constantly carries oxygen throughout your body. The cells in your body use glucose and oxygen so that energy for life can be produced in the mitochondria. The energy that keeps you right now sitting, standing, or watching this class. The energy that allows your heart to keep beating. The energy that allows us at this moment to listen to the class, to look at the screen, understanding that what we're saying in this class is that cognitive functions are carried out thanks to neuronal synapses, and these synapses consume a lot of energy. This energy, as we just mentioned, is produced thanks to the glucose and oxygen that blood constantly distributes throughout your body. We can already see here in this simulator the complex and complete cardiovascular network, which is what makes this possible. Thank you. And it allows blood to be in constant circulation throughout your entire body. And when we talk about cardiorespiratory arrest, it means that the heart stops beating. And if the heart stops beating, the blood stops flowing. And if the blood stops flowing, there is no longer any delivery of nutrients, glucose, or oxygen to the cells of your body. Some tissues can withstand longer periods without glucose and oxygen. Others cannot. They are very sensitive to the lack of glucose and oxygen. Which is one of the organs most sensitive to the lack of oxygen? The brain. The brain, folks, as soon as we cut off blood circulation, it starts to suffer, and after just 3 or 4 minutes of the heart stopping, cellular damage begins, neuronal damage, and then we have a neurological problem. So the brain cannot withstand a lack of nutrients and oxygen for very long. And it's not just the brain, but also the lungs and the heart itself. They have little tolerance for a lack of nutrients and oxygen, and the kidneys as well. The kidneys also have little resistance to a lack of oxygen. They are vital organs. That is why when performing CPR, the moment we determine that a person has died, that their heart has stopped and they have stopped breathing, we begin the resuscitation maneuver. And what does it consist of? It consists of compressing here on the lower third of the sternum. We compress right where I'm pointing with the mouse, on the lower third of the sternum where the heart's ventricles are located. If we carefully remove some of the surrounding bones and other intricate systems, we can clearly see the heart, and then we can perform a small, precise dissection where we can readily observe the 2 distinct ventricles of the heart, specifically the right ventricle and the left ventricle. And when we do compressions on the lower third of the sternum, what we are doing is forcing the heart to eject blood. We are making it pump blood. So when we compress here on the sternum, the heart ends up trapped between the thoracic spine and the sternum itself. So we make the heart eject blood. When we release the compression, the ventricles fill with blood again. We compress the chest and force the heart to eject blood. We release the chest and force the heart to receive blood. And in this way, when we perform chest compressions during the cardiopulmonary resuscitation maneuver, what we're doing is reactivating the circulatory system. We reactivate the circulatory system. That's why it's so important to remember the positioning in this lesson. Where should we perform CPR compressions? It's on the lower third of the sternum. If we do the compressions a little higher up, let's say we make a mistake and go a bit higher here, almost at the neck, where are we going to compress? If we look a bit closer, we see that at this level, not only is the heart not there, but only the great vessels are barely visible. It makes no sense to do compressions higher up on the sternal manubrium. It also doesn't make sense to do compressions on the tip of the sternum called the xiphoid process, because right at that tip, which you can feel on your own chest, if you move your hand down the sternum and feel where the bone ends, that's the xiphoid process, the tip. And if you look here at the 3D model, at the level of the tip of the sternum, we don't have the ventricles. Not even the cardiac apex, we're below that. That's why it's so important to know exactly where chest compressions should be performed so we can force the heart to pump blood. If we perform compressions in the center of the chest, which corresponds to the lower third of the sternum, right at the level of the ventricles, we force the right ventricle to send blood to the lungs. And in the lungs, that blood can be oxygenated with the reserve air that person has in their lungs. And we use that reserve oxygen so it can pass into the blood and be distributed to all the tissues in your body. And the blood that's in the left ventricle will be distributed throughout your body, already oxygenated. And that blood will reach the brain, it will reach to the heart itself so it can keep pumping to the lungs, to the kidneys, to all the tissues in your body. And this, ladies and gentlemen, is why it's important to understand these theoretical fundamentals, which will allow us to correctly choose where to perform compressions. We can see in YouTube videos, for example, that there are people who do compressions on the abdomen or perform compressions in incorrect lateral positions. If we perform a compression over the ribs, we see that the heart is not directly behind them. We could fracture a rib, and the fractured rib could puncture the pleura, a lung, or even the heart itself. That is why we always perform compressions on the sternum in its lower third. And another very important point is that we only use the heel of the palm of the hand, not the whole hand. You will be able to practice this when you attend a workshop where there is a simulation mannequin and you can do the practice. If we use the whole hand, the force is distributed over the entire surface of the hand and we go less deep. We can't perform a proper compression. On the other hand, if we only use the heel of the palm, there's less surface area and the force goes deeper. It's the principle of physics that says the smaller the surface area, the greater the depth. What we want to achieve is a correct compression. So the question is, what kind of compression do we need to achieve? How deep should we go into the patient's chest? And take note, because in adults, the depth of chest compressions during CPR should be approximately 5 to 6 centimeters. In adults, for children, take note, it's 4 to 5 centimeters. For babies, it's 3 to 4 centimeters. I'll repeat, for adults, it's 5 to 6 centimeters. For children, 4 to 5 centimeters. And for babies, it's 3 to 4 centimeters. And many people ask, but how do I know, how can I calculate these centimeters if children can be different sizes, different dimensions, just like adults? How do we estimate the centimeters? Just by looking. There is a formula that never fails, which is the original formula. What is it? That the depth of the compression should be 1/3, pay attention, of the total depth of the chest. Let's look here on the screen again at the shared 3D model. If this is the chest of a patient, then we can see that it has a total depth that goes from the back to the front of the chest. This total distance, if we divide it visually, and approximately, you're not going to take out a ruler to make this measurement. So if we visually measure the total depth that goes from the back to the chest, we are going to divide that total depth into 3 approximate parts, and the part that faces the chest, the uppermost or most anterior part, if the model is in a vertical position, is the part we need to compress. 1/3 of the total depth of the chest. In other words, we divide it into 3 parts, and the third that faces the chest is the one we need to compress. Statistics show that in adults, 1/3 of the chest's depth is statistically between 5 and 6 centimeters. That's where the centimeter measurement comes from. It's not meant to complicate things, it's just a statistical measurement. I'll repeat that. The exact way to know how deep to go with compressions is 1/3 of the total depth of the chest. Statistics indicate that in adults, that third is approximately 5 to 6 centimeters. In children, statistically speaking, 1/3 of the total chest depth is 4 to 5 centimeters. And in infants, statistically speaking, 1/3 of the total chest depth is 3 to 4 centimeters. That way, by calculating 1/3 of the total chest depth visually and approximately, we'll have a better practical reference for how deep to go. As for the rate of compressions, don't forget the speed should be 100 to 120 compressions per minute. There are many tracks on YouTube that you can use as a reference to practice at home and thus automate the rhythm and speed of compression. But we can roughly estimate 2 compressions per second. That is the proper speed. If we compress at a faster rate, we don't allow enough time for decompression, and the ventricles don't have enough time to fill with blood again, so we can't achieve good blood circulation and tissue perfusion. Therefore, the rate should be between 100 and 120. If it's less than 100, it's so slow that the circulation we manage to create with this artificial pumping is inefficient, and the tissues of the organs and systems can't be properly perfused. So the ideal rate is 2 compressions per second, that is approximately 120, from 100 to 120 per minute. We can already see how important it is to understand the theoretical principles in order to perform good CPR. Now, as we said, as soon as a person loses vital signs, they enter what is called clinical death. You can recognize clinical death because the body adapts at the moment of death. The skin changes color because what gives skin its color is the blood. And if the blood stops circulating, a process immediately begins where you can observe that the skin loses its color. In addition, the pupils dilate. There are a large number of signs that show you the person has entered clinical death. At the moment we perform CPR, we start compressing the patient's chest, and the compressions make the blood recirculate, reactivating the distribution of nutrients and oxygen. At that moment, you see that the skin regains its color, the pupils contract, and we reverse the process of death thanks to the maneuvers of cardiopulmonary resuscitation. So everyone, keep in mind that CPR is applied when we are sure that a person has lost their life. We cannot perform it on living people, because if we do CPR on someone who has vital signs, whose heart is beating, what we could cause is a cardiac arrest. So we have to be sure that this patient is in clinical death before starting CPR. So how do we know if someone is in clinical death? According to the American Heart Association, the best way to know if a person is dead or not is by checking their breathing. Checking the pulse is reserved for healthcare personnel, for lay people, meaning those who are not in healthcare. For the general community, the American Heart Association does not recommend checking the pulse, because if the pulse is checked incorrectly, someone might think the patient is alive when they are not, and then we lose the chance to resuscitate them. So with breathing, and only with that, we can make a good diagnosis at that moment and decide whether or not to perform CPR. How do you check for breathing? We are going to check for 8 to 10 seconds at most to see if the person is breathing or not. And for this, we don't need to look at their mouth or their face. A long time ago, the MAS technique was used. Look, listen, and feel. Now it's obsolete. Don't use it anymore. If you've heard about it somewhere before, don't use it anymore. The best way to know if a person is breathing or not is by looking at their chest, the person's chest. To breathe, the chest absolutely must expand. There must be respiratory movements. There are muscles responsible for this. Thank you. For the respiratory movement, the mechanical act of breathing. The main one is the diaphragm, the famous diaphragm. There are other muscles as well, the intercostal muscles, the sternocleidomastoid muscles. In other words, a large number of muscles that help with their respiratory movement. It's not possible to breathe without the chest expanding or moving. Or to clarify, in women, the respiratory movement is higher up. It's upper costal, it's higher up. In men, it's thoracoabdominal, meaning it's lower down, reaching the base of the chest and the top of the abdomen. You'll notice that in men, the belly inflates a bit lower. So we are going to look for respiratory movements in the chest in any position, but if it moves and expands, the person is breathing. If there is no respiratory movement at all, the person is not breathing. And if there is no respiratory movement for 8 or 10 seconds, we can then say that the person is dead and begin cardiopulmonary resuscitation maneuvers at that moment. That is the criterion to keep in mind for making the decision. The pulse, of course, if you are healthcare personnel, you should use it, and the protocols are different. The procedures are different, but in this case, we are talking about the basics for the general community, and we are not going to use the pulse. So, we check breathing by observing the expansion and contraction movements of the chest. Do not use the mouth to make the decision. There is a mouth movement called gasping, also known as agonal breathing, where the mouth moves like a fish out of water. The patient is gasping, and sometimes people mistake that for breathing, but it is not. It is agonal breathing. The reference is not in the mouth, it is in the chest expansion, and that's where we look for any kind of movement. 8 or 10 seconds. Is there none? Perfect. Then we start CPR. Next, we will look at the theoretical criteria, the theoretical principles for how to apply CPR. When to decide whether to perform CPR or not. We just mentioned that breathing is the criterion for the general public to know if a person is alive or dead. We check for chest expansion for 8 or 10 seconds. Now, before this, we need to apply other criteria, other principles. Let's suppose we're in a public place and someone nearby collapses. And now, since we are rescuers, we are going to assist the person and perform life-saving maneuvers if necessary. But before this, there are principles and steps we need to follow. Take note, before assisting that person, number 1, what we need to do is check if the scene, the place, the environment is safe. If there isn't a fallen high voltage cable, if there isn't a dog or a large animal that could attack me, if there isn't a criminal who could harm me, in other words, any situation that makes the place unsafe for you, you need to move away from that area, and once you are safe, call 911 or the police. But we cannot intervene if the place is not safe. Now, if this first condition is met, that the place is safe, I can now approach the person. And now we quickly have to see if the person responds or not. Okay, the place is safe. Number 2, do they respond or not? Well, there's a very simple way to know if they respond or not. Talk to them. See if they're conscious, if they're alert, if they're looking at me. If they're looking at me, they're alive. We're not going to perform CPR. So I have to check all these things quickly to know whether or not we should perform cardiopulmonary resuscitation. If the person is conscious, alert, and looking at me, then they're responsive, they're conscious, they're not dead. We're not going to do CPR. Now, if I approach the person and they're not looking at me, they're not alert, then I'm going to talk to them. I'm going to say, are you okay? Sir, ma'am, can you hear me? Are you okay? And at that point, they might answer me. They might say, no, it hurts. Well, they're in pain, they're uncomfortable, but they're alive. We're not going to do CPR. Now, if the person doesn't respond when I ask if they're okay, how they're feeling, if they don't answer at all, then we can optionally apply the pain test. We're now checking whether they respond or not. Number 2, the pain test, the pain stimulus can be done in several possible ways. One of the most commonly used methods is pinching the base of the nail hard. It hurts a lot, but it doesn't cause injury. If we press the base of the nail firmly and the person is conscious and responds, then they're alive and we won't do CPR. If they don't respond to the pain stimulus, then we can say the person is unresponsive, they're unconscious. And if they're unconscious, number 3, if they're unconscious, you need to activate the emergency medical services. You have to call 107 or the number that applies in your country and activate the emergency medical services. Always, if the person is unconscious, no matter their age group, no matter their age, we are going to activate the emergency medical services. Once the emergency medical service has been activated, meaning the ambulance is on its way, we can continue. Let's see. Number 1, if the place is safe. Number 2, if the person responds. If they don't respond, number 3, we activate the emergency medical service. If we've already completed step number 3, we move on to 4, are they breathing? And that's where we apply what we've been discussing. Number 4 is, are they breathing or not? We check for 8 to 10 seconds to see if there are any respiratory chest movements, any mechanical breathing movements. If during those 8 to 10 seconds there are no mechanical breathing movements, the person is dead. And then we move to number 5. We immediately begin cardiopulmonary resuscitation. When we perform compressions, we have to do it like this. Now we're at step 5. We compress, as we said, on the lower third of the sternum with a depth equivalent to 1/3 of the total depth of the chest at a rate of 100 to 120 compressions per minute. We compress, and this reactivates blood circulation. We're going to compress for 2 minutes. Take note, we will compress for 2 minutes. After approximately 2 minutes, I stop CPR and check if the person is breathing spontaneously, if there is chest expansion or respiratory chest movements. If after 8 to 10 seconds I do not detect any respiratory movements, I continue CPR for another 2 minutes, After 2 minutes, I pause and check to see if the person is now breathing spontaneously, if they have been resuscitated. If they are not resuscitated, I do another 2 minutes and keep repeating this until someone can replace me if I get tired, or until emergency services arrive and take over the patient. If they are resuscitated, if the person starts breathing on their own, I can't leave. I must stay at the scene and make sure they keep breathing. Why? Because they could go into cardiorespiratory arrest again. And if they go into cardiorespiratory arrest again, I start CPR again. So we have to keep a close watch on this person if they were resuscitated until emergency medical services arrive. If the person has been resuscitated and you notice that they are having trouble breathing, making an effort to breathe, or you hear a sound that indicates an obstruction or respiratory difficulty, if you see any kind of fluid like vomit or blood in the mouth, or any type of fluid that could be aspirated into the lungs, then we should place the person on their side in the well-known recovery position, which you can learn in a practical first aid workshop. At that moment, when we detect respiratory difficulty or a risk of respiratory issues due to fluids, the presence of fluids, we place the person on their side and make sure they continue to breathe. Because if we see that they have stopped breathing again, we need to start resuscitation again. Let's take a look at this next. One of the most widely taught techniques in first aid around the world is the so-called Heimlich maneuver, or airway obstruction removal maneuver. What is it for? As the name suggests, it is to clear the airway, because the airway can become blocked or obstructed by a foreign object. In this case, we're not talking about drowning like in a river, the sea, or a swimming pool. No. We're talking about an object that is blocking the airway. An example could be the cap of a pen or pencil. These caps, in fact, if someone swallows one voluntarily, that is, if you intentionally perform the act of swallowing, it will naturally go down the pharynx and esophagus to the stomach. It will hurt, it will be uncomfortable, it will feel unpleasant, but you won't die from suffocation because of that. Now, when does this object block the airway? When I'm playing with it in my mouth, biting it, moving it from one side to the other. At a certain moment, it goes too far back, touches sensitive areas, and this triggers the swallowing reflex. I swallow unintentionally. And that's when, if I swallow unintentionally, the cap of the pen, instead of going to the stomach, follows the airflow toward the lungs and gets stuck there, blocking the passage of air, and we have an airway obstruction problem. That's why manufacturers now make a hole in the tip of pen caps. That hole is so that if a child or an adult swallows it and it blocks the airway, a little air can still pass through and save that person's life. Now it could be a bottle cap or other things. An olive, a marble, a toy soldier, a little car, a coin, a chicken bone, a potato, a sweet potato. Whatever it is that causes an obstruction is a problem, folks. So in that case, we need to perform the airway obstruction removal maneuver. To better understand this theoretical principle, let's look at the 3D simulation model so we can better see what happens when there is an airway obstruction. If we look at this model from the side, we can observe by doing a small dissection of some systems and organs. We can then see, just a moment, you can see on the screen there, the mouth. Let's add a few bones so we can better see the topographical location in the anatomy of the human body. The mouth, the nose. And both the mouth and the nose end, they both join together in an organ called the pharynx. The pharynx is this organ that we can see here, now more dissected from the system. The nasopharynx, the oropharynx, and the laryngopharynx. Now we see here that the pharynx is an organ shared by both the nose and the mouth. And then from the larynx or hypopharynx, we can go backward through the esophagus, which leads to the stomach, or we can go forward toward the larynx, which goes through the trachea, main bronchi, secondary bronchi, and that leads to the lung. So here we have the airway in the front and the digestive tract in the back. And this is where the problem arises when the object, in this case the cap as an example, is swallowed incorrectly, and instead of going into the digestive tract, it goes into the airway, and that can obstruct the passage of air. In some cases, we can see here as we follow the trachea further down where the trachea divides at this bifurcation into the main bronchi, we may find some cases where olives have reached that level and of course are blocking the passage of air. This is a typical case of airway obstruction. What should be done in that situation? We take the patient. Later you'll see this in the practical part, or if you attend a workshop, you'll learn how this technique is performed. But the theoretical principle is as follows. We're going to carefully take our patient and then stand directly behind them and gently place our hands here in the discernible space we can readily find between the prominent xiphoid process, that is, the very tip of the sternum, a crucial anatomical landmark, and the navel, also known as the umbilicus. In that approximate and general space, just so you get a clearer idea and a better understanding, we're going to precisely locate the exact midpoint of that entire distance. That is, between the navel, or as we commonly call it, the belly button, and the xiphoid process, right in the middle of that space. That's where we're going to place it right there. We place our hands from behind the patient, from behind, and wrap our hands around them. With one hand, we make an OK sign with our fingers, flexing it so that the tip of the thumb forms a wedge shape. With the other hand, we wrap around the first hand and then we place the tip right in the middle of the space between the xiphoid process, the tip of the sternum, and the person's navel. From behind, we then apply force upward and inward. In other words, a force directed inward and upward. Let's look at it here on the simulator then. The force would be applied, if we look at it from the side, upward and inward. If you are behind the patient and you wrap your arms around them, placing one hand in a wedge shape and the other hand around the first, and we apply a force upward and inward, just as I'm showing you with the mouse pointer. What is the purpose of that force? That force is to stimulate the diaphragm. The diaphragm then contracts and will compress so that the lungs, of course, the lungs tend to expel the air. So by applying that force, we stimulate the digestive organs, the diaphragm, the lungs compress, they try to expel the air, and for that air to come out, the object must be expelled. It is the patient's air that expels the object. It is the patient's air. With the Heimlich maneuver then, you have to practice to know how to position yourself, because we have some very important variables. One of those variables is that the patient is not breathing and at any moment they could collapse. You need to learn in a hands-on workshop how to position yourself so that if the patient does collapse, they don't fall to the ground and hit their head, because that could cause trauma and complicate the patient's situation. So the key point, the theoretical concept regarding the Heimlich maneuver is about applying force. So to review, between the midpoint of the distance from the tip of the sternum, the xiphoid process, and the patient's navel, you apply a firm force inward and upward as many times as necessary, each time with a bit more force to stimulate the diaphragm, the lungs that want to expel the air, and the air that will push out the object. And that's how we managed to save this person's life. This is the theoretical principle. There are variations. In the case of an obese person or a pregnant woman, we can't wrap our arms around them. And in the case of a pregnant woman, if we do wrap our arms around and apply force in the position I just mentioned, we could injure the mother or the baby. So in the case of a pregnant woman, the force in the Heimlich maneuver should be applied above the base of the belly, but never directly on the belly. Never on the belly. Always above the base of the belly. We can find the same situation with an obese person, let's say someone with grade 2 or 3 obesity, so morbid obesity. We can't wrap our arms around the person, our arms aren't long enough, so we have to go higher, just like with a pregnant woman, and go above the base of the belly, and that's where we apply the compression. But I might be almost at the chest. It's okay, in that case we can do it on the chest. In the case of a pregnant woman or a patient whose morbid obesity doesn't allow us to wrap our arms around them to perform the maneuver. In the case of children or people who are sitting, we need to crouch down enough to be at the same level as the person or child and perform the maneuver. With babies, the situation is different, and we will make another video very soon so you can see the maneuver, but here we've covered the theoretical principle of why we perform the Heimlich maneuver. How it works to force air out and expel the object that's blocking the airway and putting the patient's life at risk. This maneuver is part of what we call basic life support, because if the person isn't breathing, it's only a matter of minutes before they lose their life. Now, when we perform the Heimlich maneuver, we need to be sure that the person's airway is completely blocked, not partially. If the airway is only partially blocked, the maneuver won't work, because when we apply force, the air escapes through the small amount of airflow the person still has, and it won't be effective. We have to be sure that the obstruction is total before performing the maneuver. How do we know? The way to tell is that the patient won't be able to make any kind of sound. Since it's a total obstruction, with no air passing through, the vocal cords don't vibrate. So the person can't speak, can't complain, can't scream. So when the obstruction is total, the person doesn't make any kind of sound. They may be desperate, running from one side to another, making the universal sign of choking, which is grabbing their neck with their hand, but they don't always do this. Sometimes they put their hand over their mouth, run around desperately, but they can't make any sound at all. That's when you know the obstruction is total and you can proceed with the Heimlich maneuver. Now, if the obstruction is partial, what you need to do is have them cough. Encourage the person to cough. cough, cough harder, and I encourage them to keep coughing, that we're going to help them and that they need to cough. Because coughing, in the case of a partial obstruction where some air is still passing through, is the best way to clear it, that airway. So in conclusion, if it's partial, coughing is the solution. If the obstruction is total, the Heimlich maneuver is the solution. Excellent. Next, we're going to look at the key principles to keep in mind when dealing with a patient who is having a seizure. Let's remember that there are different types of seizure. There is the absence seizure, where there are no violent jerking movements, and there are tonic-clonic seizures, which have different stages. The first stage is loss of consciousness, which can last from 15 to 20 seconds. And then comes the phase of violent shaking, which can last about 2 minutes. During this phase of violent shaking, there are many myths on the internet that say you should hold the patient's tongue so they don't swallow it. First of all, this is a myth that can cause a lot of harm. Why? Because the patient has no way of swallowing their tongue. There is no way to swallow the tongue. What can happen is that the tongue falls back and its base hits the back wall of the pharynx, which can block breathing. In that way, there can be a problem with airway patency, but swallowing the tongue is impossible. Therefore, what is being said is not correct. To grab their tongue. Also, when a person is having a seizure, their muscles are activating violently at 100% of their strength. That is, it is very risky to put your hand in the mouth of a patient who is having a seizure. The muscles that close the mouth, the chewing muscles, are called masseters. They are on both sides and they are the strongest muscles in your body. This means that if we put our hand in the mouth of a patient who is having a seizure, they can bite down with such force that they could seriously injure your fingers. So it is not correct to put your hand in the mouth of someone who is having a seizure. Nor should you put in forceps, as I've seen on YouTube. No, you'll damage their teeth. You'll injure the patient's soft tissues. You will cause significant bleeding. Do not try to restrain the tongue or put anything in the patient's mouth. If the patient bites themselves during a seizure, there will be bleeding, but you can't do anything about it. Besides, of course, pay attention that bleeding will be controlled and will stop quickly. Do not put anything in the patient's mouth. What we need to do is contain the seizures, not prevent them. If we try to prevent the seizure by holding the patient down with all our strength, the seizures will still happen, just without movement. The muscles will contract just the same, but without movement, which can cause bone fractures in the patient, to put it simply. So do not try to restrain the seizures. What we do is place pillows, cloths, or clothing underneath the patient. Under the patient's head, we support the head so it doesn't whip against the floor, move away furniture and objects that could cause injury, and wait for the seizure to pass. If we see fluids, vomit, or blood that complicates breathing, we will place the patient in the recovery position on their side so that gravity allows the fluids to drain outward from the patient's body, and do not try to clear the airway, as this could cause aspiration and further complicate the patient's breathing. So we restrain the patient, move objects away, cushion any blows with soft items, support the head to prevent it from whipping around, and stay alert to their breathing. If we notice fluids or breathing difficulties, once the seizure has ended, we place them in the recovery position so that those fluids can drain out and our patient does not aspirate them. These are important criteria to keep in mind, and we also dispel myths about swallowing the tongue and the injuries we can cause by trying to grab the patient's tongue. This is how seizures are managed. There are patients who are expected to have seizures due to their condition. There are patients who are experiencing a seizure for the first time. So in that case, of course, if someone is having a seizure for the first time, or the seizures are occurring outside the expected frequency because the patient has a certain pathology or clinical condition, we need to consult a specialist doctor so they can perform the necessary medical checkups. Very well, we've reached the point where we talk about controlling bleeding, one of the most widely taught techniques in first aid workshops around the world. Why? You may be wondering. Because an adult has, on average, a total of 4 to 6 liters of blood. A hemorrhage where blood is lost puts the patient at risk. Losing half a liter of blood is already serious. Losing a liter is very serious. A liter and a half, even more serious. 2 liters. Extremely serious. Losing more than 2 liters can be incompatible with life. The patient will go into hypovolemic shock and it will be very difficult to reverse their condition. That's why it's so important to stop a hemorrhage as soon as possible. For that important reason, please don't forget to always have readily available nitrile gloves, specifically the blue colored ones, or alternatively latex gloves in every single first aid kit, whether it's at your home or at your workplace. Make sure they are not expired. The expiration date is very important. Put on gloves quickly and then you can start working with the patient. A mask, goggles or glasses are also very important because micro droplets of blood can reach the sclera or conjunctiva of the eye or enter the mouth, and the sublingual mucosa can absorb a significant amount of that fluid. So we need to protect ourselves to prevent that from happening. The barrier, biosecurity, is an essential factor in controlling hemorrhages. In this regard, movies and TV series are misleading, because you often see in, for example, medical dramas, firefighter shows, or first aid series that they put their bare hands on the patient's wound, desperately trying to stop the bleeding. And they get completely covered in blood. Then they wipe their hand across their face and end up with blood all over their face. And of course, as I explained earlier in a class, that has a very high dose of sensationalism, but it's not right. It's not right at all. You should always protect yourselves with very important biosecurity barriers, and that's how we can control the bleeding. There are 3 types of hemorrhage. The most superficial one in the skin is capillary bleeding. These are very easy to control. But if they cover a large area of the skin, they can of course cause dehydration due to fluid loss. No matter. Now let's move on to the deeper hemorrhages, which can involve veins and arteries. Venous hemorrhage and arterial hemorrhage. You'll notice an arterial hemorrhage when the wound has reached the artery because the blood comes out in pulses as if the wound is beating. You see? So in that case, we have an arterial type of hemorrhage. Now it doesn't matter if the hemorrhage is arterial or venous. If you see that the person is losing a lot of blood from a wound, losing a lot of blood is not good. We're going to try to stop the bleeding, and how do we do that? First, we're going to grab a dressing which you should have in your first aid kit. If possible, don't use cotton, use dressings like these. We're going to place it over the wound and apply a lot of pressure, pressing hard on the wound, and we're going to stay like that for about 5, 10, 12, or even 15 minutes until the clotting factors are activated and we can stop the bleeding. If the dressing becomes soaked with blood and starts to drip, never remove it. Never remove the first dressing, because if you do, you'll take away the clots that are forming and the bleeding will return to its initial state. So never remove the first dressing. We're going to place another dressing on top of the first one and keep applying pressure, and we'll wait for the clotting factors to activate. Wait for the clotting factors to activate so we can start controlling the bleeding. We can place another dressing on top of the second one and keep applying pressure. Once we see that the bleeding has occurred and we've managed to control it, we take a gauze bandage and apply a pressure bandage to replace the pressure from our hand so we can transport the patient. This is for a significant wound. We will carefully transport these individuals to a comprehensive health center where medical professionals will thoroughly assess whether immediate stitches or any other specialized medical procedure is critically needed at that particular facility. But what we need to do quickly is stop the bleeding. Once we've stopped it, we apply a pressure bandage to replace the pressure from our hand and take the patient quickly to be evaluated by healthcare professionals. Ladies and gentlemen, in that case, of course, when the bleeding is caused by a deeper wound in critical areas, such as the lower or upper limbs, where the bleeding is already exsanguinating. What does that mean? It means so much blood is coming out, so much blood that we don't have time to wait for the clotting factors to activate, because so much blood is lost that in a matter of seconds, in just 1 or 2 heartbeats, the patient can die. In that case, a tourniquet is applied. We apply tourniquets preferably at the most proximal part of the limbs. Upper limbs, lower limbs. We are not going to see how to apply the tourniquet here. This is a class on fundamentals, on theoretical principles for first aid, but it is important to understand that the tourniquet's function is to block the artery as close to the body, to the torso as possible, so that blood stops flowing to that area. And so the patient's blood doesn't drain away and they don't lose their life. So the muscles can withstand being without blood longer than the heart, the brain, or the lung. If we apply the tourniquet we have a window of time to quickly take the patient to a health center where they can, of course, be treated by specialists, by professionals who are there to serve people. So be careful. A tourniquet, once it has been applied, you can later, or we will have more specialized classes on this channel to go over the procedures for applying tourniquets, specifically tactical tourniquets, not improvised ones. It is no longer recommended to improvise tourniquets with shoelaces, with a man's belt, or with a woman's purse strap. Let's not improvise tourniquets. This is what international guidelines recommend. We are going to use a tourniquet that we should have in our first aid kits. If possible, we apply a tactical tourniquet, and that is how we control the hemorrhage. Once we have controlled it, we note the time. The time is very important. We write it down so that later we can inform the doctor how long ago we applied the tourniquet, and under no circumstances do we loosen it. The technique of loosening the tourniquet every so often to let the blood flow is obsolete. It is no longer done. The screw that needs to be applied should not be removed until reaching the healthcare center. And that is how we control exsanguinating hemorrhages, meaning the amount of blood lost is so great that we have no time to do anything. The patient will die or not. So that's when we apply the tourniquet. This point is addressed in more advanced stages of medical emergencies in trauma care in the well-known XABCDE protocol. The X stands for the treatment of exsanguinating hemorrhages with tourniquet. Alright everyone, that was hemorrhages, tourniquets for exsanguinating cases, and hemorrhage control with direct pressure for non-exsanguinating bleeding. And that's how we contain, control, and transport the patient. One more point to keep in mind. If the bleeding allows us enough time, we can wash the injured surface, the wound, with tap water at its natural temperature. And if we have a sachet of saline solution in the first aid kit, we can use that sachet. Just cut the tip and wash the wound without touching it, letting only the stream of water fall on it. We wash it to clear away any particles that could later cause complications and lead to an infection in the patient. That's if it's possible, of course, if we don't have a sachet of saline solution in the first aid kit. Use tap water, potable water of course, turn on the cold water, rinse the wound a bit, and then quickly apply the dressing to contain the bleeding, using the necessary biosecurity elements in these cases. Very well, we're almost at the end of this class. Now we have to look at the theoretical basics of burns. Burns, ladies and gentlemen, is also a very commonly taught topic. Why? Because the heaviest and largest organ and one of the most important in your body is the skin. Among its many functions is protecting us from microorganisms that can lurk and infect our system. When a burn injures the skin, it can of course allow these microorganisms to enter and naturally put the patient at risk of infections that could complicate their life or even become life-threatening. There are two elements to watch out for in any case of burns. The first one, as I just mentioned, is infections, and the second is dehydration, which is always an important point to keep in mind with burns. Let's see that there are three types of burns, and according to PHTLS, pre-hospital trauma life support, we can see there that a 4th degree burn is also recognized. Let's take a look at what we mean by this. The skin, as you can see on the screen, has several layers. The most superficial layer, as we can see here, is called the epidermis. The epidermis is the outermost layer of the skin. Next, we find the dermis, or the skin itself, which is the second layer of the skin. And then the third layer of the skin, the hypodermis. So a burn can injure the skin at its different layers. If it injures the most superficial layer, the epidermis, we are dealing with a 1st degree burn. A 1st degree burn. Then if it significantly injures the second outer layer of the skin, which is known as the dermis itself, we are dealing with a 2nd degree burn. If the burn penetrates even deeper into the third innermost layer of the skin, we then have a more severe 3rd degree burn. If the burn goes even deeper and truly reaches the underlying muscles, the essential bones, the vital blood vessels, or the delicate nerve endings, which are indeed the nerves themselves, then according to the established guidelines of PHTLS, we are dealing with a severe 4th degree burn. This type of burn is extremely serious and requires immediate medical attention. In the case of burns, of course, 1st degree, 2nd degree, 3rd degree, and 4th degree burns, Of course, we have to consider both the degree itself and the extent of the burn. We need to calculate the extent, of course, to know how to treat that patient, especially in a hospital setting. We have to hydrate the patient and try to prevent infections or fight an ongoing infection, again in the hospital setting. Now let's take a look in specific classes at which procedures are most recommended, because burns can be caused by various things. Thermal burns are one, fire, but also cold, and they can also be chemical in origin. So depending on the cause of the burn, that's what will determine what we do. Now, what we should not do, to dispel some myths, is put tomato, fried egg, French fries, or olive oil. It sounds like a salad. There are a lot of recommendations circulating online that are false. You should not put anything strange on burns, none of that. What you should do we'll cover in a specific class, or when you can attend a first aid workshop where you can go deeper into the procedures. But now we understand the theoretical basics of why a burn can complicate things and put a patient at risk. Very well, everyone, we've reached the end of this class on the theoretical foundations for first aid. In upcoming classes or videos, we will look at the procedures for specific techniques and how to apply them based on the theory we've covered today. And we'll also cover specific cases, such as what to do in the case of stings and bites, and what to do when providing basic assistance in trauma situations. Let's remember that there are two types of medical emergencies. Medical emergencies for the medical patient and for the trauma patient. A medical patient is someone who has an illness or pathology and whose clinical condition becomes complicated, putting their life at risk. There is a risk to life. This is due to an illness. It's not like with a trauma patient where something happens in the patient's environment that impacts them, affects them, injures them, and the injury puts their life at risk. For example, an accident, a fall, a burn, an electrocution, a penetrating stab wound. In other words, these are all situations where a person suffers an injury due to something that happens in their environment, and the injury complicates their condition. So a patient can be a medical patient, a trauma patient, or both a medical and trauma patient. We also need to watch a class, a video about basic trauma care, which covers how to immobilize a patient when necessary and how to move them safely if needed. Thank you. Basic trauma care and then advanced trauma care involves other things such as stabilizing fractures to prevent the cascade of complications in a clinical patient, avoiding the triad of hypothermia, hypotension, and metabolic acidosis. All of that will be handled by trained healthcare personnel. But here we are going to start looking at more specific classes to go over the procedures so that each of you will be better prepared to apply these techniques. Thank you. These can make the difference between life and death for a person. What do you think? It's important not only that you learn this, but also that you share it. Share this class with as many people as you can, because that way we spread knowledge and awareness about how important it is to acquire these skills, which can be applied to yourself, your family, at work, or at any moment when someone needs help. You will be like a guardian angel in that situation, able to help with your hands, your knowledge, your intentions, and everything you are learning to assist that person so they can live to tell the story. I also invite you to leave your comments here on this video, in this class, and to suggest any topics you are interested in, of course, for us to cover in future classes. Share, subscribe to the channel, and turn on notifications. Thank you, and we'll stay in touch in upcoming videos or future classes. A big hug to everyone. Thank you very much, and see you soon. Bye. Thank you.